Today we'll talk about the acetaminophen, the other name also known as paracetamol, toxicity and its treatment. This was discovered in 1877 and this is one of the most commonly used drug available over the counter for pain, fever, and also this is one of the common ingredient of many cold and flu products. At the therapeutic dosage, its peak absorption is very rapid, but the absorption gets delayed in overdose scenarios. Acetaminophen overdose, intentional or unintentional, is commonly seen in the emergency department. When the patient comes to the ER, the diagnosis of Tylenol toxicity is usually confirmed based upon the acetaminophen level in the blood, the liver function test, the coagulation factor, amylase, lipase, CBC, and some electrolyte. Primarily, it causes the hepatic necrosis, which was first reported in 1966. Now, besides liver damage, renal, myocardial, and pancreatic damage has also been reported in literature. Symptoms of liver damage include yellowing of the skin, eyes, pain in the right upper quadrant, nausea, vomiting, loss of appetite, fatigue, excessive sweating, dark urine, and stool. A high anion gap may also be found in some of these patients. Mostly when it comes to the metabolism, about 85% get metabolized in the liver via conjugation through glucuronidation and sulfation, which are then eliminated by the kidney. A small percentage, about like 10 to 15%, is metabolized by phase 1 oxidation through enzyme cytochrome P2E1 to a highly reactive toxic intermediate called NAPK. NAPK stands for N-acetyl-para-benzoquinone imine. NAPK normally conjugates with glutathione to form non-toxic cysteine and mercaptopurine, which are then eliminated by the kidney. But when a large amount of acetaminophen is consumed within a short period of time, large amount of NAPK is produced, but the stores of glutathione are not sufficient to combine with all of the NAPK. So NAPK, being highly reactive intermediate, quickly binds to hepatocytes and produces hepatic necrosis. As far as the drug interactions are concerned, there are some drug which induces the enzymes, for example, phenobarbital, carbamazepine, dilantin, rifampin, and some herbal product like St. John's wort. Alcohol also induces some of the enzyme. When more in induction of the, especially this enzyme, means more of the napkin will be produced. The patient is consuming acetaminophen simultaneously, and some other drugs like opioids or zidovudine or trimethoprim sulfamethoxazole, which is like Bactrim, actually compete with the Tylenol for the glucuronidation, which means less of the acetaminophen will be metabolized by glucuronidation and more will be metabolized by the cytochrome P2E1 enzyme, resulting in more toxic NAPK. Therefore, some of the commercial products like Percocet, which is oxycodone acetaminophen, is a bad combination, for patients with the liver issue. Some other drugs which are hepatotoxic like halothane, methyl dopa, isoniazid, sodium valproate, dilantin, erythromycin, oral contraceptives, some anabolic steroid, Bactrim, statin, TPN. Why TPN? Because it causes stenosis and cholestasis. Highly active heart therapy is used for HIV infection, and some herbal products are highly hepatotoxic. Now, as far as the treatment is concerned, Epicac gastric lavage is not recommended anymore. Activated charcoal, especially when large ingestions of the acetaminophen occurs, patient presenting within about 2 hours. The antidote for acetaminophen overdose is NAC, stands for N-acetylcysteine. The brand name is called acetadote in the United States. I shall be using the NAC or the acetadote or the name interchangeably. This NAC is basically 100% effective if it's given within the 8 hours. Consultation with the poison control or the toxicologist is recommended. And sometimes if the liver damage is beyond repair, then liver transplant is the last option. A little bit about gastric decontamination. Activated charcoal is effective at absorbing or binding to the indigested acetaminophen, you know. But it's best if it's given within 4 hours of ingestion, because um, after that 4 hour, most of the acetaminophen would have already been absorbed, you know. So if activated charcoal is given within a couple of 1 to 2 hour post ingestion of the acetaminophen, it may provide additional hepatoprotection in some patients requiring the acetadote treatment. Activated charcoal should not be given in patients who are sedated or taking some other drug like benzodiazepines or opiates. And also, if you're not able to protect the airway, try to avoid using the activated charcoal in those situations. Now, binding of the acetadote to activated charcoal has been demonstrated, because if you're using the, let's say, activated charcoal and acetadote together, can you give them together? You know, there is some binding being observed, because activated charcoal is going to absorb whatever is in the gut, you know. So, for example, if you give 60 gram of activated charcoal along with acetadote, it decreases the bioavailability of the acetadote approximately by 20%. However, the current evidence suggests that a small decrease in acetadote does not alter its efficacy, you know. But if you're going to use multiple doses of the activated charcoal, then it's better to separate both the acetadote and activated charcoal at least by a couple of hours, you know. Now, before we talk about the acetadote dosing, etc., let's take a look at the Rumack-Matthew nomogram. You know, this nomogram is a great tool which can predict the possibility of hepatotoxicity, and this allows the clinician to make a decision whether to give acetadote or no. It's a basically semi-logarithmic graph. It's starting at like a 4 hour after the ingestion. Why 4 hour? Because at the 4 hour, absorption of acetaminophen is considered likely to be complete. The original line, like here, in the shown here in the yellow color, starts at like 200 microgram per ml, and this is sometimes called the Rumack-Matthew line. This was basically published in 1975 by Barry H. Rumack and Henry Matthew. When the NAC acetadote study began in 1976, the FDA required a line 25% below the 200 uh, line. So therefore, new line 100 at 50, a new line at 150 microgram per ml, which is shown here as like a green color, was added, and this was called the treatment line. What it means is that if the acetaminophen concentration is 150, is at 150 microgram per ml or higher at 4 hours after the injection of the Tylenol, then the treatment with the acetadote is recommended. Now, when, with the early acetadote treatment and supportive therapy, 66% of these patients will recover, and the remainder will progress to fulminant hepatic failure and require liver transplantation. You know, after which normally 70% of these patients will survive at least 1 year. The, the graph here basically shows how much acetaminophen is in the blood with respect to time. However, there are some limitations of using this graph. For example, we should not use this graph. The patient has ingested the drug more than 24 hours ago, or the patient has a history of multiple ingestions of Tylenol. Also, its reliability decreases for extended release formulations of the Tylenol. If the patient has ingested some opioids containing product or anticholinergic drug, you know, then the reliability of this Rumack-Matthew nomogram decreases basically. Now, now the the main the key point about the acetadote administration is the timing. Actually, very important. The optimal time for acetadote administration is within first 8 hours following the ingestion of this acetaminophen. Now, during this time, regardless of the amount ingested and the acetaminophen level, acetadote is uniformly effective during this time frame. After the 8 hour, uh, the efficacy of the acetadote or NAC decreases progressively. Now, according to the American College of Emergency Physician, they recommend using the acetylcysteine within 8 to 10 hours after the ingestion, um, like for the treatment of acetaminophen overdose, with either possible or probable risk of hepatotoxicity based upon the Rumack-Matthew nomogram. Now, use of acetadote is based on the study which was published in 1981 by Dr. Rumack and Matthew. It was actually retrospective observational data from more than 650 patients, which showed decreased hepatotoxicity when treated with NAC within 10 hours. Only 5 to 7% of those patients who received acetadote within 10 hours experienced hepatotoxicity versus 29 to 62% of the patient experienced hepatotoxicity who received NAC more than 16 hours after the acetaminophen ingestion. No mortality was shown in any group, and only those patients who deemed probable or possible hepatotoxicity based upon the nomogram were included uh, in this study. Now, subsequent studies have also shown the benefit of giving NAC even in patients with the hepatic failure. What it means is that NAC has shown some benefit outside the 8 to 10 hour window. Now, in addition to acetylcysteine use based upon the Rumack-Matthew nomogram, the other indication for acetadote use include if the patient has suspected ingestion of more than 150 milligram per kg, or someone consumed acutely like 7,500 milligram, like 7.5 gram of the acetaminophen, which is not basically doesn't look like high dose. If somebody consumes 15 tablets of the 500 milligram over the counter acetaminophen, this comes under like the toxic dose actually, so or some so the other indication of using the NAC is when we don't know how long ago the patient had consumed the acetaminophen, uh, or when the level of acetaminophen is more than 10 microgram per ml, but the patient has a history of hepatic damage, and in some situation, uh, on all of these situations, acetaminophen, um, for acetaminophen toxicity, acetadote is recommended. Now, once you have decided to give the acetadote, it comes as both PO as well as IV formulation now. Now, like which one would you give to the patient? It depends. Even though both have shown to be equally effective, however, in case of severe hepatic damage, IV next should be recommended. Actually, these days most of the institute they use IV formulation only. I'm in this profession for more than 25 years. I never used PO honestly. All the time we use it, the IV formulation. But but I just want to mention like if the PO has a almost a similar efficacy. But PO is not. I mean, is outdated. Maybe mostly due to because of its like rotten egg smell, sulfur smell, and the taste. Many patients have trouble tolerating the oral acetadote. As a result, more and more of the IV formulation is being used, in many of the institutes, and also I mean, you can overcome some of these side effects of the PO by covering the by diluting the PO formulation with some kind of like juice or soda, using a straw for the to drink it, and cover the cup with some kind of paper or lid to avoid the smell. Whereas when it comes to IV formulation does have some adverse effect like anaphylactoid type of reaction, So therefore, watch out for any possible reaction to IV acetadote. For example, sometimes a severe rash or hypotension occur with the IV formulation. I mean, something we should be aware of. Now, if you're going to consider the IV, as I just mentioned, anaphylactic reaction need to be aware of. You know, well, generally this is typically typically occurs within first 15 minutes to like 60 minutes of infusion, and it's very mild. It can be managed uh, if you give the Benadryl 25 milligram IV um, before giving the acetadote. If the patient develops anaphylactoid type of symptom like hives, itching, urticaria, then stop the infusion, treat the symptoms, and, and you can give a Benadryl or sometimes albuterol, very rarely epinephrine. Consult the poison control center so that they can record this reaction. And you can restart the infusion carefully at a slower rate unless the reaction was like life threatening. Approximately 2 to 6% of the patients treated with IV acetadote develop significant anaphylactic reactions, although rates of up to 30% have been reported in prospective trial. The majority of the symptoms are mild and consist of skin rashes, flushing. More severe reactions have been reported in less than 1% of the patient and include angioedema, bronchospasm, hypotension, and rarely death. Anaphylactic reactions are much less frequent with the PO formulation. You know, skin rashes, a serious systemic reaction, anaphylactic reaction are rarely reported with the PO formulation. However, approximately 13% of the patient develop receiving the PO vomit. So versus 7% with the IV formulation. But if somebody is like keep vomiting, then that's going to delay the treatment basically. Um, if the severe reaction persists despite giving the Benadryl and other taking other measures, then you can give the methylprednisolone like Solomedrol 120 milligram um, the, for the reaction. Mm. Epinephrine is very rarely required. Pre-treatment with the Benadryl is advised. In terms of the acetadote dosing, the dosing is different for PO and IV. As far as the oral is concerned, it's recommended as a loading dose 140 milligram per kg, followed by maintenance dose of 70 milligram per kg every 4 hours for 72 hours. Total 18 doses altogether. For the IV, the loading dose is 150 milligram per kg. The first dose, maximum 15 gram. Give this over 1 hour. Then the second dose, 50 milligram per kg, maximum 5 gram. Give it over 4 hours. And then the third dose, 100 milligram per kg, maximum 10 gram. Give it over 16 hours. I will mention some other alternative IV regimens which have been evaluated, and some center may be using them because of the shortened duration of the maintenance dose, in this alternative regimen. Now, when it comes to children, for children the dosing is same, but the amount of diluent fluid may be different based upon the child's weight. For children weighing more than 20 kg to 40 kg, loading dose is same 150 milligram per kg into 100 ml of the diluent over 1 hour, then 50 milligram per kg into 50 ml diluent over 4 hours, then 100 milligram per kg into 500 ml diluent over 16 hours. For babies weighing less than 20 kg, loading dose 150 milligram per kg into 3 ml per kg uh, diluent. So if you notice, it's only the diluent which is changing the volume, but the dose of the drug remains the same. So the only the diluent amount is changing here. Second dose, same like 50 milligram per kg, but the volume is 7 ml per kg. Give it over 4 hours. Third dose is the same 100 milligram per kg. Volume is 14 ml per kg of the diluent, and give it over 16 hours. The acetadote is generally compatible with dextrose 5% and half normal saline and still water for injection. Now, some of the things we need to ask: can we discontinue acetadote suddenly or early or once we started it, or can the acetadote treatment be repeated? When you draw the acetaminophen level on when you plot this level on the nomogram, if check if the patient it falls within the if the level fall between the possible or probable risk of hepatotoxicity. Now, discontinue the treatment if the initial serum acetaminophen concentration, when plotted on the graph, shows it comes under low risk of hepatotoxicity. Um, However, in some patients who require follow-up acetaminophen concentration, do not discontinue the treatment. In, in a patient who continue to experience the symptoms of hepatotoxicity or the liver enzyme still elevated at the completion of the 72-hour um, IV 72-hour oral treatment or 21-hour IV regimen. If the liver enzyme still elevated, then extending the treatment in those situations may be an appropriate option. However, now, which patient would require additional dose is unclear. Possibly those patients with a suspected massive overdose, simultaneous ingestion of other substances, or patient has some pre-existing liver disease or persistently elevated acetaminophen concentration, persistently elevated liver function enzyme, or elevated INR. In all this scenario, giving additional acetadote treatment should be considered. Typically additional third dose, we call third bag, 100 milligram per kg, uh, given over 16 hours. That's a typical third. However, this dose may not be adequate for some patient. Therefore, some authors recommend 150 milligram per kg as a maintenance dose infused over 24 hours. Um, Repeat this maintenance 150 milligram per kg dose over 24 hours until the signs of hepatic improvement are seen. As I mentioned earlier about the alternative IV regimen, but remember this regimen is not FDA approved. This alternative regimen has been evaluated, and some center may be using the it's a shortened duration of the maintenance dose of the IV acetadote. The regimen basically consists of 140 milligram per kg of the acetadote as a loading dose, followed by 70 milligram per kg every 4 hours for 48 hours instead of 72 hours. And the confusion might occur here. This dose 140/70 looks like the PO dose. It is a PO dose, but this is IV. Actually, it is in terms of milligrams a PO dose, but this is the IV actually. So the PO we were giving 18 doses, but this is the IV giving only for 48 hours. So this is a shortened version of the acetadote recommended by some of the authors. Well, some other like regimen have also been used, but again these are not FDA approved. They call two bag method or single bag method. IV, I mean they have been evaluated. Some centers are still using them. Clinicians should note that experience with the method is limited, and their consultation with the poison control center is recommended. The two bag method, which is off-label dosing, consists of two doses. Delivered total dose delivered is 300 milligram per kg. First dose is 200 milligram per kg infused over 4 hours. The second dose is 100 milligram per kg infused over 16 hours. The two dose method has been associated with the fewer and milder non-allergic anaphylactic reaction as compared to the manufacturer's labeled dosing. Single bag method, which is also another like off-label dosing. Total dose delivered is 430 milligram per kg. Initial bag 150 milligram per kg infused over 1 hour, then decrease the rate to 14 milligram per kg per hour infused for additional 24 hours. Sometimes the common errors I have seen, during my practice, like sometimes the doctor, like let's say, like when they look at the level, sometimes they can be a little confusing. For example, the other day we had a patient, the acetaminophen level came out to be 10 microgram per ml. So the attending discontinued the acetadote treatment. Whereas when the resident called the poison control center, this patient, the LFTs was still high in 80s. So the poison control people, they recommended to resume the acetadote treatment. So it was corrected and the patient restarted on the acetadote treatment. Um, sometime the doctor like don't give the initial loading dose. They just start with the maintenance dose. So in those scenarios you should watch out for the any dose skipped. So especially the loading dose is very important. If you're giving the if you're using a acetadote, try to give the correct dose. Now, we shall discuss three different scenarios based upon the acetaminophen concentration drawn at various times, and based upon those, is the patient supposed to get the acetadote? Yes or no? For example, in scenario number one, like we'll discuss these in terms of graph, like. Scenario number one, serum acetaminophen contains 108 microgram per ml at 8 hours after the ingestion. Scenario number two, with 320 microgram per ml and 27.2 at 7 hours and 28 hours respectively post ingestion. And the scenario number three, where acetaminophen level 10 at 4 hours and 24 hours post ingestion respectively. So let's look at the graph. For example, scenario number one, if you look at this graph, like the yellow marking on the vertical line 108 and the on the horizontal 8 hour, for this patient, the level drawn at 8 hour post ingestion is 108 microgram per ml. When you plot this on the Rumack-Matthew nomogram, so when you plot it, you see it's touching the yellow line, which is the yellow line, which is basically there is a probable risk involved here. So this patient should be getting the acetadote treatment. So look at the where the point is intersecting. Like is it uh, higher or below the green line, the treatment line? If it's below the green line, then patient doesn't need the acetadote treatment. But if it's above the green line, the patient needs the acetadote treatment. Now the second scenario, number two, for this patient, first serum acetaminophen concentration drawn at 7 hours after ingestion came out like 320 microgram. So if you plot it, that's represented as point A. And the second time they drew the acetaminophen around 28 hour post ingestion came out 27.2, so which is represent point B. Now look at point A and B, they both are above the red line, and they are in the area of the probable hepatic toxicity. So this patient should also be getting treatment. They should be treated with the acetadote and Nacetyl-cysteine. Let's move on to the third scenario. This one is a little tricky here. Like when you look at the graph, for example, at point A, and look at on your left of which the value of the acetaminophen is around like 10 at 4 hours. So I mean, if this is the case, I mean, the patient doesn't need the acetadote treatment. Now if you look at the point B, the acetaminophen level is 10 microgram per ml, but look at the time, it's 24-hour post ingestion, and point B is above the treatment line, basically uh, in the probable hepatic toxicity area. So in that case, patients should be getting the acetadote treatment. Now, if you look at point B, even the confusion here might come because the level is only like 10. So we might say level is not very high, but look look at the timing, very important. This is at 24-hour after post ingestion. So if you extrapolate it backward, the initial concentration of acetaminophen could have been very high. So that's the key. Always plot the numbers on the graph and see where it comes, and based upon that you can decide if the patient needed acetadote treatment, yes or no. you know yeah. Thank you for listening and watching. Thank you.